All right, is that better? There we go. Georgia, I did say hi. Say hi. It has been a long time. Can you guys hear me now? Somebody tell me if they can hear, because the mic is on my side. All right, I'm going to keep going because it looks fine now. It was off, you're right, but I've turned it on now. Anyway, let me start over. It is Ask Dr. Geier Live. Wherever you're watching, hope you're making today your masterpiece. This is the show where I do it once a month. I answer your orthopedic injury questions. I answer, very good. I'm glad to hear that. Thank you, Mahal, for sharing that. I answer your orthopedic injury questions, regenerative medicine questions, things like that. This is not meant for specific medical advice. I haven't seen you, examined you, looked at x-rays, MRIs, any of that. This is really meant more for you to have a better understanding of an injury you may have suffered or a surgery that some orthopedic surgeon has told you need, something along those lines. As always, try to keep the questions short as possible. If you are watching on YouTube and you can't figure out where to leave the questions, leave those in the chat, not in the comments. I cannot see the comments. I am on eCam and I just don't have access. They don't come through. All that comes through are chats. So if you see me answering questions or putting comments like George's, yes, we can hear you now on the screen, look for that in the chat, then put your question there. Every single show, after the show, I'll look and there's 3 or 4 questions. People are asking questions in the comments and I never see those, so I don't answer those. And I say that not to be rude. I just have no ability to see those because I'm not actually on YouTube right now. All right, let's start with Kushal. I apologize if I am saying that wrong. How do I transition 6 weeks non-weight bearing to full weight bearing? Had ACL reconstruction, meniscus repair. Fantastic question. I will say that there is not a one right way to do this. This is what I've done in my career, and I think it works well. I've done it with thousands of patients, but everybody's a little different. I've never been a big fan of going cold turkey, just all of a sudden going completely non-weight bearing to just no crutches, no brace, full weight bearing, and see how that goes. The leg is usually not ready for that. So again, and this is not medical advice because I don't know the specifics of the situation, but I typically do it in progression. So let's just say somebody's non-weight bearing and they have crutches. I will have them use crutches, but start putting a little pressure on it. Not their full weight, but a little bit of pressure and a little bit more pressure over the next few days. Assuming it doesn't cause significant pain and swelling, gradually increase that every little bit, not only in terms of how much weight, but how long you do it, things like that. You may only start by doing it 5-10 minutes a day, but gradually more weight, gradually for long periods of time. Then when you realize you're putting pretty much all your weight, you're putting less weight through your hands, maybe you get rid of crutches. I've never been a huge one crutch guy because of the alteration in the walking pattern. That's my personal opinion. Some people do that, but I try to go from basically 2 crutches to where, hey, people realize they're not putting any weight on their hands, go ahead and get rid of the crutches, and then gradually do more and more weight bearing. That process can take a few days, or that can take 2 or 3 weeks, depending on does it cause a lot of pain, does it cause a lot of swelling and things like that. But that's typically how I do it. I try not to go 0 to 90, 0 to 100 instantly, but sort of work up to that, and that I've had pretty good success with that. All right, good question though. That's one. Maybe I'll do a full video on that. I like that. What would you recommend for tendon graft for a site that didn't heal properly? Let me see if you followed up. It would depend on the surgery. If you're talking ACL, it would just depend. Just tell me what the surgery is. If it's an ACL, I have thoughts, but if it's a tendon for something else, I don't want to go through a long answer and then that not be what you're talking about. Happy to answer it though. Let's see, Mahal, heard a lot about PPS, penisonin polysulfate, for those of you that are not familiar with that abbreviation. 2 questions. How long does it normally take your patients to see results, and is this something people do long term? Or is it an X-week process and stop? Very, very good question. And there's not probably enough data, in my practice at least. I can just tell you I don't know, 300 or 400 patients over 4 years, my experience. But this is not necessarily what they do in Australia, where this came out in roughly 2016. I typically, even though I know in Australia some of the doctors will do 6 weeks and let's see how it goes, I have not seen that it works that fast for a lot of people. Right around 6 weeks, people are starting to feel better. So I start people at 12 weeks. And then depending on how they're doing, so I'm not a huge believer that you should really be on any medication long term if possible, and the same things here. Penisonin is a mild blood thinner, so it's something I don't like to necessarily keep people on. Now, I don't have any huge concerns about it, but if you get the pain relief and then you take a 4 or 6 week break and you still have good pain relief, the pain doesn't come flooding back, then I try to keep people off. And more often than not, people can get off of it. They may have to do another 6 week course, a couple times a year when they have a flare up. But typically for a lot of people, you can do that first 12 weeks and then be good. Some people never go on it, but a lot of people will restart it. But I do have a handful of patients that have been on it for now 2-3 years or more. They just feel better on it, and they just have stayed on it for all that period of time. We have seen really no long-term issues. We have seen some alterations or I have seen in, they get blood work drawn for routine labs, and a couple of the like liver function or kidney function ones will be slightly abnormal. I'm not sure if that's the penisonin or not, because some of those patients have just gone back and had the blood redrawn and then it was normal. They never stopped the penisonin. But that's something that we're sort of keeping an eye on. In terms of side effects, though, bruising, bleeding type stuff is all we've really seen, other than some people get like a local sort of a flare reaction, sort of thickening and irritation of the skin at the injection site. So I have people try to move it around, but that's been my experience. I have no issue with it as a long-term thing. It's just generally I try not to have people on something long-term, and I've had pretty good success having people take a break, and they do well with it. Let's see. Good questions, though, Mahal. I like that. All right. I am not going to try on that handle, that name, but good question. Can either PRP or stem cells help with a labral detachment in the hip? To my knowledge, at least for as far as either of those, I am not aware of studies for that. I think it's worth a try. My concern, especially with the PRP, but really with both of them, is there's not a lot of blood supply. You're basically trying to reattach labrum, the cartilage bumper, to the socket, to articular cartilage, and so there's not a lot of blood supply there to necessarily get it to heal, but it would certainly be worth a try, certainly avoiding a massive surgery. It's certainly worth a try if I had to guess. And stem cells is such a big category, and there's so many variables about the type of stem cell, and if it came from you, then was it allowed to replicate or regenerate to go from, like, if you stuck a needle in somebody's hip to get bone marrow, did what they do in some other countries, they take the 100 or so stem cells in there, I'm just making up a number, but then replicate, differentiate, and turn them into billions, which is typically not done here. Or was it like amniotic fluid or umbilical cord or something like that? So there's a whole lot of variables with stem cells, but and that's part of the appeal, I think, with exosomes. But I'm sort of lukewarm on PRP, but in the right setting, the right preparation, I think PRP can be a good option. But if it was me personally, this is not advice. I know what that surgery and the recovery from that is and what it entails and how long it is, and so I personally, barring if there's more information, some impingement and some other issues going on, but I am a big favor of trying to avoid surgery when at all possible. And so yeah, those are definitely options. I just had one and then I lost it. Why are some minor chronic injuries so hard to be free from, excluding arthritis? I without knowing specifically which ones you're referring to, it's hard to say. But yeah, some, especially like tendinopathies, once an area of tendon starts as a tendonitis sometimes, but then it starts to degenerate and becomes this long-standing thing, it can be really tricky. And I think it's largely because orthopedics, despite the fact that we keep talking about these being wear and tear injuries, so many of them are related to underlying inflammation. And when you don't eat well and you don't exercise and you have chronic stress and chronic disease state, states, those have negative effects on bone, tendon, ligament, cartilage, muscle that can make some of these hard to heal. And that's where regenerative can be good at getting those areas to heal, but also you got to fix the underlying issues or it's only so effective. And that's true traditional orthopedic surgery or sort of regenerative orthopedics. And I think we're starting to learn more about that as far as issues go. All right, so now we got an answer. This was the question about what I recommend here. I'll bring the initial question up. What would I recommend? Tendon graft that didn't heal properly, and he's saying ACL quad tendon. So if you're doing a revision ACL surgery, if you do a quad tendon, all options are still on the table, especially if this is a male. You could do hamstring, even though it depends on a little bit of the tunnel diameter. Sometimes the problem with hamstring is that it's a narrower tendon and it doesn't completely fill the tunnel, but that's potentially an option. You can do tissue from the other knee. You could talk to the doctor even about doing patella tendon, even if you've already had the quad tendon, or you can do cadaver. In revision set, I'm not a huge cadaver graft, allograft fan for primary ACLs, but in a revision setting, I think there's more of an argument for it. You have a little bit more leeway because you get to pick the type of not just the type of graft that you use, whether it's Achilles or bone tendon, patella tendon, bone, quad tendon, but how big it is, how old the patient was, that type of thing, and base it on the specifics of the first surgery to make sure the graft is big enough and things like that. Not a huge allograft fan for a primary surgery, though. I've done a ton of videos on that, but I'm a little more forgiving of that in a revision setting. But yes, there are some options from the patient's knee as well. I'm not a big thinking that you can reuse the same tissue, meaning if you had the patella tendon of your right knee, you can't go back and use the patella tendon of the right knee the second time. You'd have to use, say, the left knee or the quad tendon or something along those lines. What are my chances as an active 24-year-old powerlifter recovering from a shoulder dislocation, labral tear 3 to 5, 11 to 1, without surgery, stem cells, PRP an option? Potentially, but maybe not. And that is because one of the problems, they say the studies were initially 18 and under, then it sort of crept up 21 and under. We know with shoulder dislocations where there's a labral tear, there's a very, very, very high incidence of recurrent instability, recurrent dislocations, or even just subluxations where it's partially sliding out of place, but it just doesn't feel right. And that's why so many surgeons, the first time you do it, you talk about to the athlete or active person about doing surgery. Could the labral tear heal with regenerative treatments? Yes. Where I would be a little more concerned is the labral tear is only part of the issue. The other part of the issue, two parts. One, sometimes a little piece of bone gets knocked off, so it would depend on there being no bony component, but also the capsule that surrounds the ball and socket tends to get stretched out the first time it popped out of place, and I'd be very nervous that the regenerative treatment wouldn't address that part of it. And so I don't know that I'd be super confident that regenerative treatments would eliminate all of those issues. It might, and again, it's one of those things. If you can potentially avoid a surgery, that's not always a bad thing, but that would be a little bit of my current concern about going that route at all costs. Could that help you get through the season and then maybe do the surgery at the end of the season? Yeah, it definitely could do that, or you would hope it would do that, but it might work, but there's a pretty reasonable chance it wouldn't. Mike, if you want to back up healing insertional Achilles tendinopathy, what would you do? Needs to get back to sport ASAP. That's a tricky problem for what I was starting to say to the question about chronic injuries that don't heal. With the Achilles tendon, you get areas of degeneration within the tendon. So if this was me, and I've had Achilles tendonitis, and I know how limiting it is because you use your Achilles for literally everything you do, and you don't realize it until it hurts. And that was just a tendonitis, not a tendinopathy. I think you would do whatever it takes to heal. I would probably want to know in an MRI how much of the tendon is involved, because if it gets past 50% or more, you worry that even something like PRP or exosomes or stem cells, even peptides, even though I'd be a little lukewarm that the peptides would make a huge difference, but more than 50% of the width thickness of the tendon, it may be less likely, and you may be talking about a surgery to cut out the diseased portion of the tendon and either put part of a graft there or primary repair. There's different options. But if it's a small area of degeneration, if it's me, I probably do exosomes, honestly. There's more data for PRP, certainly United States data, and the data is pretty good for that. Certainly better. I would avoid cortisone like the plague. Physical therapy, if it works, great, but I'm not surprised that didn't make a huge difference. And I've not been terribly impressed with just time and activity modification and see how it goes. I think that's the perfect example of a injury or condition that regenerative treatments can be a good option. So those are sort of the things I would think about. Mahal has another question, if I can pull it up. Knee arthritis along with penisonin, unique treatments as compared to gel, steroid, PRP. I don't want to talk a lot about what I do. I've recorded a lot of videos of different options that are available in the United States. They're all still considered experimental, and I don't really use this to promote my practice. If you want to reach out to me through the contact form, there's a link in the website, in the description below. I'm happy to sort of discuss it by email or even in a Zoom consult. But my thing generally about knee arthritis is, one, steroids very clearly over numerous studies have been shown to make arthritis worse and to speed up the progression of the disease. I don't like that for many people at all, unless it's little old ladies that are already bone on bone. I just think steroids are a wrong way to go. I have no problem with the gel, the hyaluronic acid injections. I said gel. The studies are sort of lukewarm on them, but they're covered by insurance and don't really have the downsides of the steroids. For the people that it works, fantastic. More often than not, I didn't see that much benefit, but I have no issue with that. PRP, another good option. Again, it really depends on the concentration and a lot of specifics about the PRP, but that can be a good option. There's starting to become good data with exosomes. Stem cells, there's a lot of variables. I like the places in other countries that do it really well and have a lot of regenerative capability with stem cells. But that really gets into much bigger discussions. But along with penisonin, and I think combining the two options can be a very good thing because they sort of work differently, but both very reasonable options. If the graft, I see what he's saying. So if the graft, there we are. His graft donor site didn't heal. I don't know what would be the easiest way to go there. If the graft donor site didn't heal, what tendon graft, because that's such a rare thing. I honestly, I'd have to really know more about it. I'm not sure, if that's something that just primarily close the defect. If that doesn't work, what the kind of the best option would be. He's saying abnormal. Yeah, this is getting into a little bit more of specific medical advice, and I don't know enough about that to comment as far as what is going on in your case. But could regenerative options be an option? Absolutely. Carrie Wells, any other options you might suggest for shoulder impingement? So yes, she said other than physical therapy. Big fan of physical therapy, and I think that's generally where most people should start because that's usually enough to get people better. I think after that, I would probably want to know what's going on. That may be getting an MRI, but just make sure the diagnosis is right, that there's not actually an underlying cuff tear or labral tear or something like that that's the reason it's not getting better. If it's truly that there's no structural issues and the physical therapy is not getting better, again, it'd be a little tricky because not everybody is failing for the same reason, but it would be considering injections of some sort. Again, not at all a steroid fan. I know the data is out there and the orthopedic surgeons will tell you no big deal, but especially in a young person, we know that steroid can weaken rotator cuff tendons. And I just don't think that's necessarily a good thing. So could PRP be helpful? Something along those lines. I mean, even peptides for the right person. It would depend a little bit on the specifics of the exam. And again, is there something going on the MRI that was the reason that the impingement, that they didn't get over it? But absolutely big fan of starting with physical therapy. All right, this is going to be the last one I do today because I've got another live show in a few minutes for the military veterans out there, but we'll do Mike's. if I get a doctor to do high concentration PRP, do you think that would really move the needle in terms of recovery? I do. I think there aren't that many places that do the high concentration ones, and I'm not going to suggest certain brands, but I know that the most traditional orthopedic surgeons use PRP that are made by the surgical companies, the Arthritis in the world, and I've not been as thrilled with that as the ones that really make high concentration PRP, which is more expensive, a little bit more elaborate. But if you're going to do it, that's kind of the route to go. The nice thing about PRP compared to stem cells or exosomes, even though there are ways to do exosomes where it's coming from your body, but with the PRP, it's coming from you. You're not getting tissue from somewhere else, from a donor. And stem cells, where they just get it from your bone marrow. Once you hit, I don't know how old Mike you are, but if you're hit 35, 40, you just don't have all that many functional stem cells left. And so I'm sort of lukewarm that the stem cells of that. Now there may be other aspects of the bone marrow that are helpful, but there are some concerns about stem cells. But I think well done quality PRP can be a good option. All right, I will stop with that. Very, very good questions. I very much appreciate that. And I finally get to talk regenerative. Usually nobody asks about any of that stuff and they just want to know, sort of traditional stuff. But I love talking about this. Very, very happy you're here. Next month, I push it back a week to September 8th because September 1st is Labor Day and I will not be doing a live show on Labor Day. I don't think you want to be at the, if you're American at least, you want to be at the beach or the pool or things like that. You don't want to be tied to YouTube. But very excited to be here, but just mark it down for September 8th. I will be here same time, same place. Very excited that you join me. I look forward to seeing you in all our weekly videos and in the live show in a month. You have a great rest of your summer and I'll talk to you soon.